Bismillah ar-Rahman ar-Rahim. This is the last chapter. We are going to talk about how to discuss and how to make an interpretation to the ABG. We'll discuss different cases, especially the mixed problems. Before we start, as I have mentioned before you start looking at the ABG chart, it's better first. You have to study and discuss the clinical status, through which you will anticipate what are the expected problems or what is the expected problem, and then look at the lab investigations. Don't rush to the ABG alone. The ABG will not give you except possibilities. In order to escape from this, I have to focus on the clinical status of the patient and lab investigations, which will guide me to the anticipated or expected problems. Then look at the ABG. From these data, come to the chart itself, this monograph, and fill all the data. Put all the data. And then start to calculate these items, these monitors we have discussed before. Corrected bicarbonate, chloride sodium ratio, anion gap, corrected anion gap, strong ion differences, buffer base, strong ion gap, base excess or deficit, alveolar action, and then the alveolar gradient. From these data, you'll start to discuss alone, keeping in mind what is the anticipated problem. Look at this. This is a simple case. 8 years old diabetic patients. He's a diabetic. Stress. Look at this. This is diabetic patients. Came with respiratory distress. Clinically was fever. Respiratory distress, fever, and random blood sugar was high. Just X-ray pneumonia. So this is the clinical state of the patient with some data lab investigations. And this is the chart of the patient, the ABG chart. What is the diagnosis of these patients? What is the problem of these patients? Then we have to put these data here in this monograph. pH of the patient is 7.33, carbon dioxide 23, bicarbonate 14, sodium 130, potassium 3, chloride 100, and what else? This is alveolar. This is arterial oxygen 110. FI2, he was on room air. Then we start to calculate these monitors. Corrected bicarbonate, chloride sodium ratio, corrected anion gap, strong ion differences, buffer base, strong ion gap, base excess, alveolar oxygen, and then alveolar gradient. Let's start with this patient. This patient was diabetic. Diabetes was high blood sugar. So I expect that this patient developed some sort of like metabolic ketoacidosis. Ketoacidosis, this is high anion gap metabolic acidosis, in which the keto acid neutralizes part of the bicarbonate, so the bicarbonate is decreased. This is the pH. When you come to this, pH is anacidotic. Look at the carbon dioxide is less than 40, it is 23. So when it is 23 and the bicarbonate is 14, so this goes with the expectation that this patient is having some sort of metabolic acidosis with compensatory respiratory alkalosis. But what is not the reverse? Maybe he may having some problems. He's having tachypnea or hyperipnea, and he is losing, pushing out carbon dioxide, and the bicarbonate should decrease. But in this case, if it is an acute problem, if there is washout of carbon dioxide, the kidney will not compensate. It will only lose 3 to 4 milliequivalent of bicarbonate. So the expected bicarbonate in this case will be about 20 or 21, something like that, not 14. So this is not like that. So is it a chronic problem of chronic hyperventilation? So with washout of carbon dioxide, in this case, one loss of bicarbonate of carbon dioxide will be associated with loss of 0.5, and this is not the case also. So it is from the history that it is expected to be high anion gap metabolic acidosis with washout of carbon dioxide. Look at this. This is a corrected bicarbonate. Corrected bicarbonate, this means the bicarbonate plus the anion gap minus the minus 12. What's the anion gap? Anion gap here, look at anion gap equals, this is the sodium minus chloride plus bicarbonate, and all of this is anion gap is very high. It's 22. So this is high anion gap 10 more than 12, over 12. High anion gap metabolic acidosis. So this is goes with our best relations. When you come to C, the corrected bicarbonate, this means the bicarbonate 14 plus 22 minus 12 gives 24. So this patient was normal. His bicarbonate was normal before this problem or before this pathology. So this gives us this is a patient who was normal and he developed some sort of diabetic ketoacidosis, which resulted in washout of carbon dioxide. Look at again, when you look at strong ion differences, strong ion differences, no change in chloride and bicarbonate or sodium. That's why the chloride to sodium is the same. It's normal, 74%. So chloride minus sodium gives you 40. So this is a normal strong ion difference because strong ion difference changes only with normal anion gap metabolic problems. But this is high anion gap. Again, when you look at the buffer base, there is lots of bicarbonate, so the buffer base is less than 40. This is anacidotic. This is due to loss of bicarbonate. This is a buffer base told that there is lots of bicarbonate. This is an acidotic, but the strong ion difference told that this is not a normal anion gap metabolic acidosis because it is normal, but this is high anion gap. This is high anion gap metabolic acidosis. When you can look at the base deficit or excess, base deficit or excess, when you calculate it, it's minus 13, it's base deficit. So this is high anion gap metabolic acidosis. When you come to the study, the lung, the patient was on room air. His oxygen was normal. When we calculate the alveolar oxygens, 117 minus this arterial oxygens, alveolar arterial gradient is 7. So there was no problem for this for the oxygenation of the patient. But what happened for this patient? This is a partial emission of carbon dioxide here. The expected carbon dioxide should be 28 because you know that loss of bicarbonate 1 will be associated with washout of 1.2 carbon dioxide. Here 10 will be associated with loss of 12. 12 minus 40 gives you 28. But here the patient made more washout of carbon dioxide. So this washout of carbon dioxide in response to acidosis. But there is another factor which is mechano or stature receptors in the lung due to the presence of pneumonia. So the washout is a little bit more in addition to the fever. So I expect something like that. So this patient is having a simple metabolic acidosis due to DKA with compensatory respiratory alkalosis, and in addition to this is more washout of carbon dioxide due to the presence of pneumonia. This is the first one. Look at the second one. This is another bit, little bit more complicated. This is a 45 years old alcoholic. This is an alcoholic man, has been vomiting for 3 days. He stayed for 3 days vomiting. Vital sign, look at the blood pressure. 45, maybe hypertensive, something like that. This blood pressure is low. Going to the CT is not shocked, but it is that there is impairment of perfusion to the tissues, tachycardic. And in addition to this, the patient received Valium because there was some tremors or irritable, something like that. So I have here more than one problem. Vomiting for 3 days. Vomiting means loss of chloride. Vomiting leads normal anion gap metabolic alkalosis, retention of bicarbonate. Okay. In addition to these hypotensions or hypoperfusion, lactic acidosis, high anion gap metabolic acidosis. Is it like that or something like that? And the Valium may add to the problem. The patient, the ventilator problem may be suppressed with more retention of carbon dioxide. These are the data for the patient. Look, when you come to monograph, when you start the monograph, this is a patient I've mentioned. This patient was vomiting. Vomited. Look at this. This pH is 7.3. 7.3. This is an acidotic. Look at carbon dioxide is 40. 40 with acidotic patient. Bicarbonate is low. So this is a this is decrease in the bicarbonate. This is metabolic acidosis, and there should be wash out of carbon dioxide, but the carbon dioxide is not washed. The patient took Valium. Might be. Maybe due to this problem, or the patient might have some other problems. When you look at the anion gap of the patients, this is a sodium, this is a chloride, and this is a bicarbonate, and the anion gap is high. This is high anion gap, 30 instead of being 12. High anion gap, metabolic acidosis. What the problem? What if the patient we mentioned that he was vomiting for 3 days and after that started to develop hypotension or the perfusions, lactic acidosis? What would the bicarbonate before he develops this shock? This corrected bicarbonate. Corrected bicarbonate. This means the bicarbonate plus 30 anion gap minus 12. Corrected bicarbonate 37. 37, this is true because the patient started to vomit. Vomiting, there's a loss of chloride, which is replaced with concomitant increase in the bicarbonate. So the patient had beforehand, when he was vomiting, hypochloremic metabolic alkalosis. How did you know? This is a chloride is less than normal, and the chloride to sodium ratio is less than 74. So this means that there is loss of chloride, so the chloride ratio is less, and at the same time, when you come to see the bicarbonate is high. So the patient with vomiting developed a hypochloremic metabolic alkalosis. And what happened else? The patient started to be volume depleted. And the volume depletion, this is the patient, the perfusion of the tissues and the blood pressure came down, started to develop lactic acidosis. How did you know? This is bicarbonate decreased from 37 to 19. And after that, when you look at the buffer base, or the buffer base here is instead of being 40, it is 35. So this is a metabolic acidosis. But look at the strong ion differences. Strong ion differences, this is a difference between sodium and chloride. But chloride lost. So that's why the patient was, according to the strong ion difference, is metabolic alkalosis. And this is a clue for the previous state that the patient had metabolic alkalosis. Because I didn't make anything for this patient. He lost the chloride, sodium is normal, and they give me these pictures, and this is a clue for this. This metabolic alkalosis is strong ion difference. Metabolic alkalosis, normal anion gap metabolic alkalosis, but developed later on some problems with hyperperfusions, with loss of bicarbonate to develop high anion gap metabolic acidosis with loss. When you look at strong ion gap is not, should be 0. It is 14 because the presence of lactic acid. So this is a strong ion gap, which is the difference between these strong ion difference and the buffer base is 14. So this is a clue for what happened for these patients. Look at this. The patient also, in addition to this, here is Valium. When you look at this bicarbonate 19, there should be a shot of carbon dioxide. One loss of bicarbonate will be associated with loss of carbon dioxide by 1.2. This is loss of 6. This should be of 5 should be associated with loss of 6. So the expected carbon dioxide is 34, but now it is 40. This most probably due to the volume he received. This is the data of the patients. This is the oxygen for this patient's normal, and the alveolar gradient is normal. So there is no pathology for the lung. The oxygenation problem of the lung is normal, but the problem is hypoventilation to the volume. And the patient first, when you look at this, the patient developed vomiting, loss of chloride, increase in the bicarbonate, hypochloremic metabolic alkalosis, and then developed hypoperfusions was loss of bicarbonate and the same chloride. This is high anion gap metabolic acidosis, and in addition to this, the volume made some sort of suppression to the respiratory center, and therefore the patient became hyperventilated with retention of carbon dioxide instead of being 34, became 40. And from this data, you can calculate the water deficit for this patient by its formula. So this is a way to discuss the patient with ABG. And thank you.